بسم الله الرحمن الرحيم. اللهم إني أسألك علما نافعا. صدق الله العظيم. The lecture today is about bone loss and the pattern of bone destruction, and I'm Dr. Omima Afify. First, we have to know that the height and density of the alveolar bone are normally maintained by an equilibrium regulated, of course, by local and systemic influences between bone formation and bone resorption. When resorption exceeds bone formation, so bone height, density, or both are reduced. The local factors and systemic influence which regulate this equilibrium. Local factors are the gingival inflammation or chronic gingival inflammation and how it is spread to the underlying periodontium and cause bone loss and trauma from occlusion or a combination of both. And we will illustrate this in the next slides. So, it is important to know that the degree of bone loss is not necessarily correlated with the depth of the periodontal pocket, the severity of the ulceration of the pocket wall, or the presence or absence of pus. Why? Because the level of bone is the consequence of the past pathological experiences. Okay, so it is not correlated, bone loss not correlated with the depth of the periodontal pocket, the severity of the ulceration, the inflammatory process, and so etc. So, the first stage in bone destruction is the chronic gingival inflammation and how it spreads to the periodontium or extend to the periodontium. We also have to know first that periodontitis is always preceded by gingivitis, of course, but all gingivitis progresses to periodontitis because if it is treated well controlled, cases of gingivitis well controlled, it will not progress to a periodontitis lesion. So, extension of inflammation is chronic gingivitis is associated with changes in the composition of the bacterial plaque, in the cellular composition of the inflated connective tissue cells, and through the tissue invasion of some periodontopathogenic microorganism. The transition from gingivitis to periodontitis first is associated with changes in the composition of bacterial plaque. So in advanced stages of the disease, the number of motile organisms and spirochetes increases, whereas the number of coccoid rods and straight rods decreases. Also, the cellular composition of the inflated connective tissue also changes with increasing severity of the lesion. Fibroblasts and lymphocytes predominate in stage 1 gingivitis, as you know, where the number of plasma cells, blood cells, increases gradually as the disease progresses. So, it is believed that as the lesion becomes a B lymphocyte lesion, predominantly B lymphocytes are present, it becomes progressively a destructive lesion. So, extension of inflammation from the gingiva to the periodontium has two main pathways. Number one, the interproximal pathway. Number two, the buccal or facial or lingual pathway. The interproximally, I will show now the diagram how the infection or the chronic inflammation of the gingiva spreads to the bone interproximally. First, you have to know that inflammation spreads to the loose connective tissue around the blood vessels, or inflammation is concentrated around the blood vessels and spreads through the blood vessels. So, inflammation spreads to the loose connective tissue around the blood vessels through the fibers, the gingival fibers, the transeptal fibers, and then enters the bone through vessel channels that perforate the crest of the interdental septum at the center of the crest, toward the sides of the crest, or at the angle of the septum. Then it may enter the bone through more than one channel. It is less frequently that inflammation spreads from the gingiva directly into the periodontal ligament and from there into the interdental septum. It only occurs in case of trauma from occlusion, which modulates or changes the direction of the inflammatory process directly toward the periodontal ligament. Now in the diagram you show the pathway of inflammation from the gingiva into the supporting periodontal tissues in periodontitis. So interproximally you see inflammation spreads from the gingiva in the loose connective tissue around the blood vascular or the blood vessels, destruct the gingival fibers, then the transeptal fibers, and enters the bone, the crest of the interdental bone, the crest of the bone, and then from the bone to the periodontal ligament. Okay, it may perforate the center of the crest or from the outside the crest, as we said, and then from this situation to the periodontal ligament. Less frequently, the inflammation spreads from the chronic gingival inflammation spreads directly to the periodontal ligament, and this only occurs, as I mentioned to you, in cases of trauma from occlusion, which modulate or change the direction of the action. Then this is the other pathway, which is the facial and lingual pathway. This is the inflammation spreads, as you see in this diagram, from the gingiva along the outer periosteal surface of the bone, and then penetrates into the marrow spaces through vessel channels in the outer cortex. In this case, facially and lingually, here the chronic gingival inflammation may spread directly to the periodontal ligament, not as in the interproximal, which is not commonly or not often occurs except in cases of trauma from occlusion. But here, facial lingually, it may spread direct to the periodontal ligament. Okay, what happens when inflammation enters the bone? Inflammation replaces the marrow with leukocytic and fluid exudation, new blood vessels, and perforating fibroblasts, of course. Multinuclear osteoclasts and mononuclear phagocytes increase in number, and the bone surface appears lined with house-shaped lacunae. It becomes pitted, or bone becomes perforated. But in the marrow spaces, what happens? The resorption occurs not from outwards to inwards, no. It proceeds from within, causing thinning of the surrounding bony trabeculae and enlargement of the marrow spaces. This is followed by the extraction of the bone and the reduction in the bone height. So it proceeds from within outwards. It is important to know what are the transeptal fibers. Along the course, as I mentioned, from the gingiva to the bone, the inflammation destroys the gingival and the transeptal fibers. What are the transeptal fibers? The transeptal fibers, as you know, are located interproximally. They extend from cementum of one tooth to the cementum of the neighboring tooth, their function is to protect the interproximal bone and maintain tooth-to-tooth support or tooth-to-tooth contact. Then what is the function, what is the its clinical significance? When the chronic gingival inflammation spreads and destructs these fibers, alhamdulillah, there is a continuous tendency to create the transeptal fibers across the crest of the interdental septum. This is a gift from Allah because these dense transeptal fibers are of clinical importance because it protects the underlying bone. So when you make a flap operation and remove all the granulation tissue, okay, when you do surgical procedure to eradicate the periodontal pockets and remove the granulation tissue and etc., you see that the transeptal fibers, it is encountered to you. You will be encountered by these transeptal fibers. They form a firm covering over the bone. Okay, this is the clinical significance of the transeptal fiber. We are continuing bone destruction caused by the chronic inflammation. We have to know now there is radius of action. What we say radius of action. You know what is the radius? The radius is the half of the diameter. So it was postulated that locally produced bone resorption factors have to be present in the proximity or close proximity of the bone surface to be able to exert its action. Okay, so it was postulated that there is a range of effectiveness of about 1.5 to 2.5 millimeters within which bacterial plaque can induce bone loss. Beyond this distance, 2.5 millimeters, there is no effect. What about interproximal angular defects, large angular defects, which they can appear only in spaces wider than 2.5 millimeters. Because why? Because narrow spaces are destroyed completely. So when we see large defects far exceeding 2.5 millimeters, which you can see in certain conditions as in aggressive cases of periodontitis and the papillon-Leber syndrome, it may be caused by the presence of bacteria within the tissues, invasion of bacteria within the tissues. Okay, so you have to have the range of 1.5 millimeters to 2.5 millimeters. This is the range of effectiveness of the bacterial plaque, or the locally produced bone resorption factors from the dental plaque. Okay. As we mentioned, that large defects far exceeding this distance, as in aggressive types of periodontitis, may be caused by the presence of bacteria in the tissues, as AA, P. gingivalis, P. intermediate. This is virulent. These are virulent microorganisms which can invade the tissues. Also, as I said to you, interproximal defects can appear only in spaces that are wider than 2.5 millimeters, because in narrow spaces would be destroyed entirely. Okay. We will see this in this diagram. This is a lower incisor. As you see, there is a thin labial bone. So, when the radius of action or effectiveness is within the range of 1.5 to 2.5 millimeters, there is complete destruction of this thin bone. because it is within the effectiveness of these locally produced bone resorption factors. Okay, as you see in the left diagram, resorption, horizontal bone resorption, and then when you go apically, it is changed to what? To an angular bone resorption or angular defect. It is angular form oblique resorption. Okay, see, in fact, or really, bone resorption begins as horizontal bone resorption. Then, as we go apically, it changes to a angular bone resorption. In this, in the upper molar, in the middle of this diagram, with when the bone is thin, facial bone, horizontal bone loss occurs. Here in these upper molars in C, you see that these upper molars have thick facial bone. This is allowing for vertical bone loss because a bone will be resorbed at when it is in close proximity to the locally producing bone resorption factors, but the bone away from the range of effectiveness, 2.5 millimeters, will not be affected easily. So angular bone loss will be occurred. Then the rate of bone loss, as you see, not to go through it for a long time, you have to know that rate of bone loss depends on the type of the disease, of the periodontal disease. Chronic periodontal diseases, not bone resorption is not equal to that of aggressive periodontal. This is a research. It doesn't matter to read it or not, but I want you to know that bone loss is more rapid and great in cases of aggressive periodontitis lesion than in lesions of chronic periodontitis. Then the other item is the periods of destruction. So periodontal destruction, as you know, it is an episodic, intermittent fashion. Destruction in periodontal disease occurs in episodic, intermittent fashion, with periods of inactivity or quiescence. Okay, there is periods of activity and periods of inactivity or quiescence. The destructive periods result in loss of collagen and alveolar bone with deepening of the periodontal pockets. Now, what are the reasons for the onset of destructive periods? This may be due to bursts of destructive activity are associated with what? With subgingival ulceration and an acute inflammatory reaction resulting in rapid loss of the alveolar bone. This is not number one. This is a continuity with the above point. Bursts of destructive activity coincide with the conversion of predominantly T lymphocytes, as we mentioned in the beginning of the lecture, to one with a predominance of B lymphocyte plasma self-infiltrate, and I mentioned to you that when the lesion becomes a B lymphocyte lesion, it becomes a more destructive lesion. Periods of exacerbation also associated with the increase of the loose unattached motile gram-negative anaerobic pocket flora or microorganisms, and in the reverse, the periods of remission coincide with the formation of a dense unattached non-motile gram-positive flora with a tendency to mineralize. Also, an important factor, as we said in the, as you remember in NUG, the tissue invasion with the spirochetes. If you remember, or I remind you, by NUG, tissue invasion occurs with spirochetes. So tissue invasion by one or several bacterial species, as AA, P intermediates, P gingivalis, spirochetes. These are followed by an advanced local host defense that controls the attack. Then the second, we talked about the local factors which contribute to the equilibrium between bone formation and bone resorption. Then what about the systemic factors? Bone loss initiated by local inflammatory processes may be magnified by systemic influence on the response of the alveolar bone. So the response, in other words, the response of the alveolar bone to locally produced bone resorption factors is magnified or modulated by systemic influence of any diseases such as osteoporosis, which is a physiologic process, or some skeletal diseases. This is termed the bone factor concept. So what is the bone factor concept? It means that bone loss initiated by local inflammatory processes may be magnified by systemic influence on the response of the alveolar bone. Example 1, osteoporosis. As I said to you, that it is a physiologic condition. Osteoporosis, you know that osteoclasts are the resorbing cells, bone cells. So osteoclasts remove the mineral portion of the bone, while mononuclear cells and macrophages and lymphocytes degrades the organic matrix of bone. So osteoporosis is a physiologic condition of postmenopausal women, resulting in loss of bone. As I said to you, the mineral content and structural bone changes. Periodontitis, you might have to know that periodontitis and osteoporosis share a number of risk factors. What are these risk factors? Aging, smoking, diseases, medication that interfere with healing. The other example of periodontal bone loss may also occur in generalized skeletal disturbances as hyperparathyroidism, leukemia, Langerhans cells histiocytosis. So this occurs by mechanisms that may be totally unrelated to the usual periodontal problem. Okay, these are because these skeletal disturbances modify the response of the alveolar bone or magnify the response of the alveolar bone to the locally produced bone resorption factors. Then the other factor which affect the equilibrium between bone formation and bone resorption is, as we mentioned, trauma from occlusion. We mentioned that spread of chronic gingival inflammation to the underlying periodontium and causing bone loss. Then bone destruction may be caused by trauma from occlusion or combination of both. You took already trauma from occlusion, and you know about it, many informations about trauma from occlusion. I will pass it quickly. So you have to know that the changes caused by trauma from occlusion vary from increased compression and tension of the periodontal ligament, increased osteoclasis of the alveolar bone, to necrosis of the periodontal ligament and bone, and resorption of bone, and both structures of these changes are reversible. Okay? Why these changes are reversible in primary trauma from occlusion? Because it does not affect the supercrystal fibers, so it is reversible. But persistent trauma from occlusion results in funnel-shaped widening of the crystal bone portion of the periodontal ligament with resorption of the adjacent bone. These changes, which may cause the bone bony crest to have an angular shape as you studied before. Also, when combined with combined bone destruction caused by trauma hormone combined with inflammation, this aggravates the bone destruction caused by the inflammation and causes bizarre bone patterns. So we have to know that trauma from occlusion may cause a thickening, as you know, of the cervical margin of the alveolar bone, or a change in the morphology of the bone. So it may cause thickening or change in the morphology of the bone. So it may make buttressing bone formation, this is the thickening of the cervical margin of the bone, or it may cause a change in the morphology of the bone, which are the angular defects. So what is buttressing bone formation? Bone formation sometimes occurs in an attempt to buttress bone trapecally, weakened by resorption. When bone is resorbed, bone itself tries to buttress itself by deposition of more bone. When this bone deposition occurs within the jaw, it is termed central buttressing bone formation. But when it occurs on the external surface, it is referred to as peripheral buttressing bone formation. So the peripheral buttressing bone formation causes bulging of the bony contour. You can see it. You can see bulging on the gingiva because there is bulging on the underlying bone, because you know that the gingiva mimic the underlying bone. This is called bulging of the or the peripheral buttressing bone formation. It also may called lipping. It is called or termed lipping, like lip. It is bulging like lip, termed lipping, which sometimes accompany the production of osseous craters and angle defects, as we will see in the second part of the lecture. This is the peripheral buttressing bone formation or lipping of the facial bone. See the deformity of the bone produced by this buttressing bone formation, and the bulging also of the mucosa, or the bulging of the gingiva. Okay, food impaction also may be a primary factor in bone defects, because the pressure and irritation from the food impaction contributes to the inverted bone architecture. What we say, a converted or a negative bone architecture. Also, a complicating factor may occur in a case of poor proximal relationship. I will show you now what is the inverted bone architecture. Inverted bone architecture occurs when the interdental bone in more apically than the facial or lingual bone, as I will show you now. Also, in juvenile periodontitis, the vertical or angular pattern of alveolar bone destruction is found around the first moles, as you see in gingival juvenile periodontitis. Horizontal bone loss first. It is the most common pattern of bone loss. As we mentioned, in periodontal disease, the bone is reduced in height, but the bone margin remains roughly perpendicular to the tooth surface. This is a horizontal bone loss, and the bone margin of the bone remains perpendicular to the tooth surface. This is a horizontal bone loss. Then the osseous defects. The other is the osseous defect or the angular defect. Their presence may be suggested on radiographs. You can see osseous defects, but careful probing and the surgical exposure of the area is required to determine their exact conformation or configuration and dimension. This Figure B shows you vertical or angular bone loss on the distal root of the first molar. This is angular or trough, like hollow trough of angular bone resorption. So from this, we concluded that vertical or angular defects are those that occur in an oblique direction, leaving a hollowed out trough in the bone alongside the root, as you see in the previous slide. The base of the defect is located apical to the surrounding bone. This is in the reverse of horizontal bone loss, where there is a bone loss, but the bone margin remains roughly perpendicular to the tooth surface. But here, this is an angular or an oblique defect. You have to know the definition of the angular or vertical angular defect. What is the definition of the vertical or angular defect? So, then, angular defects are classified on the basis of the number of osseous walls. In fact, on the basis of the number of intact or present osseous walls. They may have one wall defect, angular defect, two wall angular defect, or three walls angular defect. Or the fourth type is the combined osseous defect. The combined osseous defect occurs when the number of walls in the apical portion of the defect may be greater than that in its occlusal portion. I will show you this in the next diagram. What we see here in this the left slide, we see three bony walls. What are these three bony walls? This is the distal wall, number 1, 2, this is the lingual wall, number 3, this is the facial wall, but the mesial wall is completely destroyed. So this is one wall, this is a three wall defect. Three wall angular defect. To not be confused, make as I will tell you. Three wall angular defect means a defect with intact three walls. This is three wall angular defect. We speak about, or we correlate the angular defect in relation or regarding to the intact walls or the present walls. So this is a three wall angular defect, or in another word, it is, you have to know this, an intra-bony defect. Three wall angular defect or intra-bony defect. And then in B, you see here two walls only, intact walls. This one is the distal wall and 2 is the lingual wall. So this is a two wall angular defect, or a defect with two walls, with the presence of two walls. There is two walls, okay? It is very simple. In C, what we see here, we see intact one wall only, which is the distal wall, but the facial, the lingual, the mesial wall are distracted. They are absent. So this is a one wall defect, or in other words, a hemiseptal defect. Hemiseptal defect or hemiseptum. This is a hemiseptal defect. So this is a defect with one intact wall, to be not confused. What about here? This is, we see here, there is absence of the distal, of the mesial wall. There's, we have the lingual wall, we have the distal wall, and we have half the buccal or the facial wall. Okay, so the wall in the apical portion is more than coronally. In the apical portion, there are three walls. Okay, in the more coronally, there is two walls. So this is called a combined defect. A combined osseous defect. 3 walls in the apical half, as you see, and 2 balls in the occlusal half. I hope you got this information. And this is in another view. You see here in the left slide above 3-walled bone defect. There is 3 intact walls, but the medial wall is absent. In 1-walled, this is a 3-walled bone defect. Don't forget that this is named also intra-bony defect. This is 1-wall defect, the other slide in the right side. This is 1-wall defect. What is the 1 wall present? This is the lingual wall. Here, the lower slide shows you 2-walled bone defect, which we have only 2 walls intact or present. The lingual wall and the mesial wall. Any two walls, buccal and lingual, lingual and mesial, lingual and distal, etc. Any 2 walls, it is named 2-wall bone defect. So we have to know also that these vertical defects, when you see an X-ray, you can detect that there is a vertical defect, there is an angular defect. It can be seen in the radiograph, but the facial and lingual or palatal defects cannot be seen in the radiograph because it will be obscured by the opacity of the root. Also, the radiographs cannot tell you or give you an information about how many walls are destructed, at what is the type of this angular defect. If it is 1, 2, or 3, or a combined defect. Only surgical exposure is the only way to determine the presence and configuration of the vertical osseous defects. Radiograph is an aid, but it cannot tell you the type of these angular defects. As I mentioned to you, 3-wall vertical defect, I stress on that, it was originally called an intra-bony defect because it is a defect, with bone all around except 1 wall. This is an intra-bony defect. While 1-wall vertical defect is called what is called a hemiseptal defect. Or see here. There is in this radiograph 1-wall vertical defect on the mesial surface of the left lateral incisor. As you see, there is 1-wall defect, and the distal wall and the half of the labial wall, as you see here, the distal wall and the half of the labial wall of the left lateral incisor, and this is named what? This is a combined defect. The other bone pattern defects, pattern of bone loss, is the osseous craters, which is very, very important. Osseous craters, what are osseous craters? Are concavities in the crest of the interdental bone, confined within what? The facial and lingual walls. This is the osseous crater, concavities in the crest of the interproximal bone, confined within the facial and lingual walls. The height of the facial and lingual crest of the crater may be identical, may be at the same level, or with increpancy, or with higher facial crest or higher lingual crest, one is higher than the other. The high frequency of interdental crests, osseous craters, are mostly occurs in the lower molars, in the mandibular molars. Most frequently in mandibular molars. The high frequency of these interdental craters may be suggested because of The interdental area collects plaque and it is difficult to clean, as you know. The normal flat or even concave bilingual shape of the interdental septum in lower molars may favor crater formation. Also, the vascular pattern from the gingiva to the crest, to the center of the crest, may provide a pathway of inflammation. I mentioned to you in NUG, revised NUG, I mentioned this point in NUG, the vascular pattern from the gingiva to the center of the crest, which provide a pathway of inflammation. This favors high frequency of the See here, this is an interdental crater, as you see. This is an interproximal crater. In figure in the left side or this in the right side. Interdental crater bone resorption is first observed in the interdental area and the periodontal lesion progresses. The area is made of spongy bone. Spongy bone in the interdental, in the crest. This is made of a spongy bone. It is between two cortical bones, rich in blood vessels. So pathway of inflammation in the crest enters this spongy bone, which is rich in blood vessels and causes bone resorption. And it is a fertile ground for the initiation of the inflammation. Inflammation spreads in this area. First, the region of the interdental septum is resorbed like a shallow cup. It is sometimes found not only in the interdental area, but it may be seen in the buccal and lingual aspects where the alveolar housing is thick. But with the same, it is destructed completely. But it can occur when the alveolar housing of the bone of the teeth is thick. Okay? And this is the interdental crater. This also shows you the normal in the left side, the normal bone contour interproximally, and this is show you the left endogram in the left and the right side shows the osseous crater interproximally. Then the other configuration of the pattern of bone loss is bone ledges. What are bone ledges? Bone ledges are plateau-like bone margins, which are caused by resorption of thickened bony plates. When you have buttressing bone formation and their resorption may occur, there is a bone ledge at the periphery of the marginal bone, thickening of the marginal bone. This is called or named ledges. Okay. Also, this is the bone ledge, labial ledge produced by interproximal resorption here. This is caused by interproximal resorption, not by resorption of the thickened bone. This is by interproximal resorption. This is a bone ledge, as you see. For occasional involvement, I pass this title because you took forcation involvement in details with Dr. Nassar, and you know about the class 1, class 2, class 3, class 4, and different shapes of the forcation involvement. I will not repeat it again. But I want you to know that all these are named changes in the pattern of bone loss. Bulbous bone contours. Bulbous bone contours are bony enlargements caused by exostosis, adaptation to function, or what we say buttressing bone formation. This is the adaptation to function or buttressing bone formation. I mentioned to you that when bone is resorbed, bone tries to buttress itself or support itself by the position of more bone, so it will cause excessive bone formation or buttressing bone formation. They are found more frequently in the maxilla than in the mandible, buttressing bone formation. Also, what is found more frequently in the maxilla than in the mandible, the inverted bone architecture or the negative bone architecture. This figure reflects a full, shows you a reflection of a 4-thickness flap from the alveolar bone, and then you see what you see, an exostosis or thickening of bone margin. When we remove or make osteoplasty, and we will illustrate and discuss this osteoplasty and osteotomy in the next part of the lecture. Then we trim the bone, protuberance or bone thickening or bone bulging, and reshape the bone contour, and then adapt the flap again to its position. This is the reverse architecture, as I mentioned to you, or the negative architecture. Reverse architecture are produced by loss of the interdental bone, as you will see in the foot impaction in the previous slides, including loss of the interdental bone, including the facial plates, lingual plates, or both, but without concomitant loss of the radicular bone. Bone covering the root of the teeth, all the roots, the alveolar bone housing covering all the roots, is called the radicular bone. Okay, it's called the radicular bone. So reverse architecture are produced when loss of the interdental bone, including the facial plates or lingual plates or both, but without concomitant loss of the radicular bone, buccally or lingually, thereby diverging the normal architecture. Such defects, as I said to you, are more common in the maxilla. I will show you. This is the inverted or reverse architecture, as you see. There is loss of the interdental bone, okay, without concomitant loss of the of the radicular bone. You see, this is all the alveolar bone housing covering the teeth is the radicular bone. So the radicular bone in a more coronal direction or more coronal level than the interdental bone, and this is not the normal. The normal is the interdental bone in a higher, more occlusal than the marginal bone or the buccal or lingual bone. So reverse architecture, this is the prop in place in deep infrabony pocket on the mesial surface of maxilla premolar, and this is in the right slide, elevated flap. We elevated the flap, and this shows the angular bone margin with notching of the interdental bone, or what we say the reverse or negative architecture. Thanks you very much, and we will continue how to manage or correct these osseo defects in the next part of the lecture.